Hello, welcome and kumusta? Thank you for joining me. This is How, your occupational therapist, and welcome to OT Conversations. This is a podcast intended to students, intended to young clinicians who would like to update themselves with some information about occupational therapy. This podcast sometimes can be some relevant information involving occupational therapy. It can be a celebration of people, which can be a rollicking individuals of occupational therapy, or some random discussions about ordinary things or random information involving occupational therapy, or sometimes it can be a rant involving occupational therapy. Whatever the topic may be, it's going to be a riot conversation. What's exciting today and what do we want to talk about? We are going to talk about a cerebellar stroke. So what do we know? So about stroke is stroke. It just meant that somebody's brain did not get the right blood supply or the right amount of blood, in which case it has and it will affect somebody's brain function. Now, the most common symptoms of a stroke would be the one that is mostly shared in the media, which would be fast, which would be facial weakness, arm weakness, speech disturbance. And if those things have been identified, then you need to think fast and you need to act fast and you need to call emergency services. That would be the usual scenario. There will be some situations, however, when it will give you a red herring or it will spin you out of your comfort zone, because those symptoms, the facial weakness, the arm weakness, or the speech disturbance, may not present itself clearly, on which case you will be thinking, what's wrong with my patient? This is especially true if you're working in the hospital and you're looking after a patient, and then all of a sudden some symptoms just come about. And when they turn out to be something that is different, then you would think, what is this? You'd be worried about the scenario, and the chances are it's not within the normal stroke symptoms. And if that is the case, then you might think that the person is actually faking it. And I have worked with cases and lots of cases in the past where people and clinicians are quite quick to blame psychology and are quick to put psychology in the reasons why a person is showing the symptoms. So they're making it like psychogenic. But there will be some stroke symptoms that is out there, but it's not within the normal parameter of the FAST. And a typical scenario would be one that is on the posterior circulation, or when somebody has had a cerebellar stroke. So posterior circulation would be the one that is supplying the back or the end part or the posterior side of the brain, in which case you will have some symptoms where you can have some visual problem. It can be cortical blindness, it could be hemianopia, especially if area 17 or the occipital region is impaired. But if that is spared and the problem is the cerebellum, then you can have a cerebellar stroke. And what's interesting about a cerebellar stroke is that the motor problems, is not contralateral to the lesion. So if you have somebody who has a right-sided cerebellar stroke, then you would expect problems on the right side of the body. It could be on the arm or it could be on the legs. So just be mindful, because it will really throw you off guard. It's not the usual contralateral with cerebellar stroke. It will be ipsilateral. The symptoms are ipsilateral. So that's one way on which this thing is different. Another way where it can be different is that the arm is strong. So there is no weakness on the upper limb. And when there is no weakness, when you resist the upper limb, your patient will be able to give that resistance, and you will wonder as a clinician, and you might think that it is not a stroke because the person is not weak. Yeah? So strength is not it's not a huge problem with cerebellar stroke on some situations. But a person may not be able to move the upper limb with ease. Or sometimes you see them and they don't feel that they can move the arm. But if you start to resist it, they will be moving against your resistance. So you might think that the person is actually faking things. And why would you do that? Of course, it's quite obvious, isn't it? You ask them to move their arms, they can't do it, they can't move it. And yet, when you put your arms to resist against their arms, they'd be able to push very hard and they'd be able to pull very hard. And if you ask them to grip your hands, they'd be able to do that as well. So what's going on? The story is, and the reason is, the problem with cerebellar stroke is that proprioceptors may be concerned. So it is the proprioceptors that is the problem, meaning the position sense, those Golgi tendon organs. Mind you, the cerebellum is the integration for the proprioceptors. A good proportion of movement and proprioceptors are all integrated in the cerebellum and position sense, so that you can actually move without needing to think about things. So that's what cerebellum does. So you have the natural swaying of the upper limb. Coordination would be something. Again, these are all impaired in the cerebellar stroke. And when you resist against the upper limb, then you are actually providing sensory facilitation and sensory input onto the proprioceptors. And once that is stimulated, the brain acknowledges that it's there, then the person will be able to actually. Okay, so these are the things that would be impaired. The other thing with cerebellar stroke is that you can have problems of gross incoordination. And how would you find out a gross incoordination? Do a finger to nose test. A person could have difficulty with this because, again, it's position sense, and so finger to nose test will be impaired or could be impaired. It's not all the time, it's never consistent. Different people, different scenarios, different cases altogether. You have to treat it based on what you actually observe. That's one. So a person may have problems with their coordination, particularly when they're doing their finger to nose test. Patient may not have problems with their strength, but with their initiation of movement, then they would have problems with that. The other thing that a person may have problems with is the balance or the vestibular subsystem. What patients might say is that their head tends to be swimmy or bouncy. So again, this will trick you into thinking that the person has a vestibular problem or inner ear problem. Why is that? Again, the ear and the vestibular subsystem is also integrated in the cerebellum as well. You know how I know that? So balance is actually integrated in the cerebellum. So there's a lot of influence there. Why do I know that? And how do I remember that? Is because of the actual cerebellum. So that's one way to remember it. Bell. So the bell, it involves some swinging, and it will have to do with balance and the hearing as well. So the cerebellum will be the one where it will be integrated, and it could be integrated as well. Finger to nose test, that is likely to be impaired. The other thing that you need to keep an eye on is this symptom called adiadochokinesia, is inability to perform rapid alternating movements. This is called adiadochokinesia, or diadochokinesis is impaired, yeah? And you can do this by quick tapping, hand tapping, or reverse hand clapping. where you clap against the hand, and you can see that the good side is much better, and then the bad side, it's much more difficult to coordinate things. Okay, very simple, guys. Cerebellum. This will put you off guard, but just remember of some of the things that I mentioned to you. Symptoms are ipsilateral. Strength is going to be normal. There's likely going to be an impairment in terms of coordination, and balance can be impaired as well. And when balance and coordination is impaired on this side, the person will be walking in a wide-based gait. They can be walking in a wide-based gait as if they are drunk. That's what they would normally say. It feels like they are drunk. But when they tip over, because of the writing and protective extension or reaction that is integrated in the cerebrum, then they are able to balance themselves. But they are really staggering and wavy, just like they are drunk. Okay, there you go, guys. Those are the symptoms of cerebellar stroke. When you see that, when you see these symptoms, take note of that. Be comfortable and be confident about the symptoms that you are observing, and do not be quick to blame psychology into it. Let's try to go on the very easier explanation first. And usually there are some problems that is because of another part of the brain, and it is on the posterior side, posterior circulation, and that is called the cerebellum, and hence that is the story of cerebellar stroke. Okay, I hope you find this episode informative and entertaining. Just to let you know, I am saying these things out of experience and coming from my memory. What I would like you to do now is try to read about it, learn about it, and talk to your friends about it. Grow together, learn together, improve as an occupational therapist. At the end of the day, this information is a very basic foundational information and foundational skills for an occupational therapist, so that you'll be able to perform your ADL assessment and ADL retraining much better. Okay, guys, until next time, bye. If you enjoyed this podcast, talk to your friends and colleagues about it. Like it, subscribe, share, and do what you can to appease whatever algorithm that is at play. Just remember, guys, anything you do matters and has an outcome. Until next time, bye.